So once again, we'll just go through the anatomy. This is the RB septal surface, the septal tricuspid leaflet, the coronal muscle of Lanzesi, the anterior tricuspid leaflet, the posterior tricuspid leaflet, anterior and posterior tricuspid commissure bounded by the anterior papillary muscle, anterior papillary muscle connected to the septal band by the moderator band. The moderator band was cut here. This is the point of attachment of the moderator band. The moderator band continues as the septal band. The septal band turns posteriorly into posterior division and anteriorly into anterior division. In the posterior division, the coronal muscle of Lanzesi gets inserted. The posterior division now curves around the inner curvature of the heart to become the parietal band, and this completes the infundibulum. So now we have the pulmonary valve here. We'll make a little bit more cut on the pulmonary valve and then we'll turn over to the left side. So I am making a cut across the pulmonary valve into the pulmonary artery, almost like a transannular patch. So now we will visualize the parts of the pulmonary valve. Pulmonary valve is a 3-leaflet valve. So this is the pulmonary valve leaflet. So it's a semilunar valve leaflet with a curved attachment. So there is a curved attachment. It's like a crown. So the crown has got a nadir point, that is the lowest point, and a highest point. The highest point is the commissure. The lowest point is the nadir. So this is the pulmonary valve leaflets. Now when you do a procedure such as pulmonary root translocation, such as say a Ross procedure, the pulmonary valve will be cut off along this line. So this infundibulum is actually a freestanding structure. You will be able to separate it out from the heart. So for a Ross procedure, you will be cutting along this line and along this line and taking out a small cylinder. That cylinder will have all the 3 valves, 3 leaflets, and that will be lifted out and implanted in the aortic position. So the locations of the ventricular septal defects, the inlet VSD is below this portion. The distal end of the inlet septum is defined by the caudal attachments of the septal tricuspid leaflet. This whole area is the trabecular muscular VSD. Yesterday's patient, if you remember, it was a posterior muscular VSD, somewhere in this location. The perimembranous VSD will be here, intraconal VSD will be here, subpulmonic VSD will be here. We will open the left side of the heart and then we will put in pins into various areas. So now we are going on to the left side. When we look at the left side of the heart, this is the small finger-like left atrial appendage. The left atrium is a very small atria compared to the right atrium. That's the reason why it is having less of compliance and very easy to have elevation of the pressures the moment there is a mitral regurgitation, as for example following balloon mitral valvotomy. There is an acute elevation of the left atrial pressures. Left atrium does not tolerate it at all. Right atrium is more tolerant because of the right atrial free wall, right atrial large appendage. It's more compliant chamber. It is very difficult to raise the V wave of a right atrium. It's very easy to raise the V wave of a left atrium. Heart failure with preserved ejection fraction, people get flash pulmonary edema due to sudden elevation of V waves. Venous filling wave may markedly increase. Now coming to the the blood vessels that enter the left atrium. Behind the left atrial appendage, this is the left atrial appendage. Behind the left atrial appendage, the two left pulmonary veins join the left atrium. The left upper pulmonary vein is closer to the mouth of the left atrial appendage. When you see on a transesophageal echocardiogram, the ridge between the left atrial appendage and the left upper pulmonary vein is called as the Coumadin ridge or warfarin ridge. So this is the left upper pulmonary vein and left lower pulmonary vein. If you carefully look from the left side of the heart, the left upper pulmonary vein will be marginally be anterior and the left lower pulmonary vein will marginally be posterior. Actually, this will be the anatomical location. So I'll put in an artery forceps in the left upper pulmonary vein. And I'll put in another forceps in the left lower pulmonary vein. Left lower pulmonary vein. You will observe that left upper pulmonary vein is marginally anterior, left lower pulmonary vein is marginally posterior. So now we'll introduce a forceps through the left pulmonary vein and come out of the right pulmonary vein. This posterior wall of the left atrium is actually in close relation to the esophagus. That is where we do the transesophageal echocardiography. So, I'll again orient you. So, we have actually gone from the left pulmonary vein to right pulmonary vein. This flap of structure is the pericardium. Pericardium is only attached posteriorly. So, this flap of the pericardium is now the oblique sinus. My finger is now within the oblique sinus. So I will lift this pericardium to show the oblique sinus. The oblique sinus is the sinus that has got two left pulmonary veins on the left side, two right pulmonary veins on the right side, plus superior vena cava on the top and inferior vena cava on the bottom. So this is the oblique sinus. So I'm going to trim off the whole of the pericardium in the region of the oblique sinus. So this pericardium now has been cut off. Little bit more of the pericardium is there. Thank you. So now we have exposed the posterior wall of the left atrium. So now we have to enter through the posterior wall of the left atrium into the to see the left AV valve. The structures that run in the posterior wall of the left AV groove are coronary sinus and left circumflex artery. Now what we will do is we will open the right heart and advance a probe into the coronary sinus and then come and see this structure. So now, this is the ostia of the coronary sinus. This is the ostia of the coronary sinus. This is the tendon of Todaro. This is the septal tricuspid leaflet, and this is the triangle of Koch. So through the ostia of the coronary sinus, we have advanced the forceps. Now with this forceps, we will again go back to the posterior left atrial wall. What I am palpating here is the tip of my forceps here. So this is the coronary sinus. So the coronary sinus is sitting at the floor of the left atrium. So unroofing of the coronary sinus leads to blood from the left atrium entering into the coronary sinus and coming out into the right atrium. A small amount of blood can enter from the coronary sinus into the left atrium, causing milder degrees of desaturation also. So this is the coronary sinus. All the mitral annuloplasty techniques that are transcatheter, that involve annular reduction, will be based on coronary sinus. So there will be coronary sinus, carillon ring and all are based on coronary sinus. So you constrict the coronary sinus, you will get that mitral annulus reduced. When we open the mitral valve, then we will see the mitral valve structures. So in order to get the mitral valve opened, the first incision I will make between the left atrium, right pulmonary vein to the left pulmonary vein, so that we horizontally we open out that. So now we have opened the left atrium. We will extend this incision into the left atrial appendage. Left atrium is strikingly a different structure compared to left ventricle, right atrium. So here, if you look at this left atrium, right atrium was a highly pectinate structure with a lot of rough areas, whereas left atrium is by and large a very smooth surface. Everything will be smooth. The posterior wall of the left atrium, where the pulmonary veins join, the body of the left atrium, all the places will be smooth, the only exception being the left atrial appendage. So that's the reason why in non-valvular atrial fibrillation, thrombus most of the time forms only in the left atrial appendage, and hence if you arrest the left atrial appendage or if you exclude surgically a left atrial appendage, most of the time the procedures work without anticoagulation. Left atrial thrombus will only form if there is a mitral inflow obstruction. In the presence of a normal mitral valve, left atrium, it is difficult to get a thrombus with the exception of left atrial appendage. So left atrial appendage is the only pectinate part in the left atrium. So this is the left atrium, the pectinate part of the left atrium. I'm opening out the left atrium. Left atrial appendage may have multiple lobes. So in this particular patient, if you see, there is here one lobe and there is here one lobe. So the portion, this portion is called as the ostium of the left atrial appendage. About 6 to 10 millimeters below, the left circumflex artery will be closing. The place where the left circumflex artery is closing will be called as the landing zone. The landing zone is the place where devices such as amulet and Amblasser cardiac plug will be placed, with the belly will be on the landing zone. The beginning is called as the ostium. So ostium followed by landing zone, and then there is something called as a depth of the left atrial appendage. If you don't have a sufficient depth of the left atrial appendage, a device cannot go and sit. So a minimum distance should be around 10 millimeters. Most of the left atrial appendage will have 10 millimeters. So this is the depth. What I am measuring now with my forceps is the depth. That is from the ostium to the tip of the. Now we are visualizing the left upper pulmonary vein. This is the left upper pulmonary vein. Now, if I tilt it, this is called as the Coumadin ridge. This portion is called as the Coumadin ridge, what I am now holding. Now we get into the mitral valve. In order to see the mitral valve, I'm going to make more incisions on the posterior wall of the left atrium longitudinally. This will be cutting through the coronary sinus, and you will find that my artery forceps is there. I'm actually let it be. I'm cutting through the coronary sinus and I will expose my artery forceps there. So that is the coronary sinus. So you have come out of the coronary sinus. So the left posterior AV groove will have both the distal parts of the circumflex artery as well as this coronary sinus. I am taking out the coronary sinus catheter and I am going more to cut the posterior mitral annulus. Now let us expose the mitral valve. The mitral valve has got an anterior mitral leaflet that is very, very large, and a posterior mitral leaflet which is very small. Since the heart has become a little rigid, I will cut more so that we see a little better. If you have a fresh heart, it's soft, but it degenerates faster. If you have a formalized heart, it does not degenerate, but it becomes very hard. So now we have exposed more. This is the posterior mitral leaflet, and this is the anterior mitral leaflet. If you look at the characteristics of the anterior mitral leaflet, anterior mitral leaflet is actually a triangular leaflet. The triangular leaflet will have an anterior annular attachment here. This anterior annular attachment is called as the aortomitral curtain. It occupies 2/5 of the mitral circumference, 2/5 of the mitral circumference. This anterior mitral leaflet is attached to the aortomitral curtain basally, and this is the free edge. It's triangular in shape. There are two ends. This is called as the anterolateral trigone, and this is called as the posteromedial trigone. The posteromedial trigone overlies a structure called as the central fibrinous tendinous body. On the right side of the central fibrinous tendinous body, the penetrating AV bundle will be there. Usually, during a mitral valve replacement, AV block cannot occur because the central fibrinous body or the right fibrous trigone is on the right side of the on the left side of the penetrating AV nodal bundle. But let us assume this annulus is 27 mm and the surgeon puts in a 31 mm prosthesis. The stretch can produce AV nodal block. Second possibility is this AV nodal conduction tissues are more vulnerable for damage in patients who are having AV canal defects. Reason why it is so is, in AV canal defect, the aorta is unwedged. Aorta moves anteriorly. Here, just behind this anterior mitral leaflet will be the aorta. So aorta will wedge inside, thereby pushing the AV node more towards the right side of the heart. Whereas when the aorta is unwedged and moves anteriorly, the AV node is more at a risk of injury. So what we are lifting up is the anterior mitral leaflet, and what we are lifting here is the posterior mitral leaflet. The posterior mitral leaflet, in comparison to the anterior mitral leaflet, is more rectangular. It is small from the base to the tip. Anterior mitral leaflet is very large from the base to the tip. Posterior mitral leaflet is very small from the base to the tip. So the point of coaptation is always very posterior on the mitral annulus. So in other words, you will have a smiling face type of coaptation in a mitral valve. It is not a central coaptation. It's a slide. It's not like a bicuspid aortic valve where it is a central coaptation. This is a smiling face type of coaptation. So it's more posterior. This intertrigonal distance is of significant importance for mitral valve repairs because mitral ring annuloplasties are based on intertrigonal distance. So you measure the intertrigonal distance. The intertrigonal distance is equal to the distance of the anterior mitral leaflet's length of the leaflet. The length from the attachment to its free edge is equal to the intertrigonal distance.
Sir, what we measure in mitral annulus in apical four-chamber wave will correlate with which?
Will be the hinge point of the posterior mitral leaflet to hinge point of the anterior mitral leaflet. When we are taking an apical when we are taking a parasternal long axis view, the mitral annulus that we measure will be the hinge point of the anterior mitral leaflet at the level of aortomitral curtain, and the hinge point of posterior mitral leaflet at the level of left atrioventricular junction, and we take it, that is the parasternal long axis mitral annulus. In an apical four-chamber view, we will be measuring across the A3 segment of the anterior mitral leaflet to the P1 segment of the posterior mitral leaflet. So it will be like in this plane. So A3 to P1. What is A1, A2, A3? Look at the left atrial appendage. So this is the left atrial appendage. Whatever is closer to the left atrial appendage is the left trigone, or it is also the anterolateral fibrous trigone. So this left fibrous trigone is A1. The portion of the AML that is in left fibrous trigone is A1. The mid portion is A2, and the third portion is A3. So the most medial portion is A3. In apical four-chamber view, you will measure A3 to P1. In parasternal long axis view, you will measure A2 to P2. So this is the mitral annulus.
Sir, and one more question, sir. In case if we tell that mitral annulus is 27 mm, is it sure that it correlates with the same introp?
Okay, mitral annulus is slightly a oval structure. The mitral annulus in a normal heart will slightly be a oval structure with very minimal difference between the anteroposterior diameter, that is between the A2 to P2, to the lateral diameter. However, when in a pathological mitral valve, the mitral annulus dilates, it dilates not on the aortomitral curtain but on the posterior mitral annulus. So the posterior mitral annulus keeps on enlarging. So the direction of enlargement will be more and more and more posterior, thereby leading to anteroposterior diameter becoming larger than the lateral to lateral dimension. So the mitral annulus progressively dilates posteriorly. Similarly, the tricuspid annulus progressively dilates across the anteroposterior tricuspid commissure. So it's the free wall that will keep on dilating. The septal leaflet will remain constant. So now we have the posterior mitral leaflet here. I am going to cut off the posterior mitral leaflet because then only we will be able to expose all the parts of the. So now I have cut the posterior mitral leaflet. I am now cutting through the cavity of the left ventricle up to its apex. So now I am laying open the anterior mitral leaflet. I will now lift the anterior mitral leaflet. This is the anterior mitral leaflet, which is triangular in structure. This is the posterior mitral leaflet. If you look at the posterior mitral leaflet, I will put in the forceps into the posterior mitral leaflet behind it. You will observe that the entire posterior mitral leaflet is a very small from the base to the tip. Similarly, here also I will show it is very small from the base to the tip. So posterior mitral leaflet is not very vital for coaptation. Posterior mitral leaflet is actually only a support against which anterior mitral leaflet will go and attach. So let's assume there is a mitral annular dilatation acutely occurring. When there is a rheumatic carditis, there is a rheumatic valvulitis which fails to co-opt nicely because of the valvular leaflet thickening, and there is an acute onset of mitral regurgitation. This acute mitral regurgitation leads to acute annular dilatation. This annular dilatation now makes the anterior mitral leaflet unable to come and touch the posterior mitral leaflet. So the anterior mitral leaflet actually overrides the posterior mitral leaflet. So the problem of acute rheumatic carditis is acute thickening of the posterior mitral leaflet leading to its immobility, and that results in initial MR. That initial MR leads to acute annular dilatation, and the posterior mitral leaflet moves away from the anterior mitral leaflet. The anterior mitral leaflet now overrides. Overrides means what? The two leaflets should come and touch each other, and now it's not able to touch. So it overrides. It comes to this point. So at that point, the MR begets MR. The posterior mitral leaflet is actually a very small leaflet. In cases of mitral valve prolapse, they will get elongated. But in the normal heart, posterior mitral leaflet is a very small leaflet. Posterior mitral leaflet chordae, now I will lift it. There are three types of chordae. One is the basic from the papillary muscles. So there are two groups of papillary muscles. These two groups of papillary muscles divides into multiple heads, and from there is a first order chordae, then there is a second order chordae, then there is a third order chordae. Basically, it is like a tree-like branching, and there are multiple branches. You are able to see the multiple branches. So it goes into first order, second order, third order. The average length of a chordae in a standard adult will be 17 millimeters. That's the reason why majority of the caudal, neocaudal placements by the surgeons will be targeting like 17 millimeters. 16 to 17 millimeters is the standard length of a neocardiac, of a chordae. So if you look at it, all these are roughly about 16 to 17 millimeter. In a formalized heart, it will be little contracted and shortened, but in real life, it will be 16 to 17 millimeter. These chordae are attached to various areas. Those that are attached to the medial part or the central part of the leaflet, these are called as the paramedian chordae. Those which are attached to the commissure is called paracommissural chordae. So these chordae, paramedian chordae and paracommissural chordae, are the edge chordae. They attach to the edge of the leaflet. But truly, majority of the chordae will be attached to the posterior leaflet, posterior part of the leaflet. So they are called as the strut chordae. So now I'm going to lift this chordae. I'll just divide the posterior mitral leaflet a little bit, and now I will lift the posterior mitral leaflet. If you look at it, can you see the attachment of the papillary muscles? See, the papillary muscles are attached to the posterior side or the ventricular surface of the leaflet. They are called as the strut chordae. These are the chordae that give the strength, the strut chordae. The paramedian chordae and paracommissural chordae are the tip chordae. These are the strut chordae. These are the strut chordae. So the strut chordae go on to attach onto the ventricular surface. So whenever the ventricle contracts, the leaflet is not thrown out into the atrium. The leaflets are continued to be held on towards the ventricular side. So this is the strut cardi. Imagine if the leaflets, if the cardi are all attached only to the tips, there will be many patients who will have prolapsing, billowing mitral valve. So strut cardi are the main cardi in all the leaflets. After some time, I will open the anterior mitral leaflet also, and I will show you the strut cardi. Strut cardi are the most important cardi. Then there is a third type of cardi called as basal cardi. Basal cardi are directly from the posterior wall of the left ventricle to the posterior mitral leaflet. We'll try to see that also. I'm now making a finer incision of the posterior mitral leaflet. So now I'm going to lift the posterior mitral leaflet. If you look here, sorry, I cut it off. There was a cardi. See, these areas, they will be independent of the papillary muscles, and they will be attaching to the basal portion. So you can see one here also. So these are cardi that come from the posterior ventricular wall and directly getting inserted onto the posterior mitral leaflet. So this completes the posterior mitral leaflet, the papillary muscles, the cardi, the paramedian paracommissural, strut cardi, posterior basal cardi, and now we are going to cut across the aortomitral curtain. This portion is called as the aortomitral curtain. So we are taking as I am cutting the aortomitral curtain, I will enter into the aorta. So now I have cut the entire anterior mitral leaflet. I will lift out this and show the strut cardi. So now on the posterior surface, you will see that there are a lot of cardi. These cardi are the strut cardi. Similarly, I will show here. These are the strut cardi. See that the entire posterior ventricular surface of the anterior mitral leaflet is full of strut cardi. It's a clot here which will take it out. Now we will enter into the aorta. This is a potential space. Now I have entered into the aorta. We already saw that the aorta and the pulmonary artery are separated by the transverse sinus. So this is the transverse sinus. Now we have exposed the potential space. I have cut through the aortomitral curtain and I have gone out of the heart. See, can you see my finger there with the glove? That is my finger with the glove. I'll bring it out. So that is the finger with the glove. So that's a potential space. The anterior wall of the left atrium to posterior wall of the ascending aorta is a potential space, transverse sinus. So now this is the aortic valve. We'll make a little bit more cut so that aortic valve can be opened a little bit better. So now we have exposed the aortic valve. So these are the tri-leaflet aortic valve. So this is the aortic valve leaflets. Now these two were the mitral valve leaflet. This is the mitral valve that I have cut off. So now I have separated the mitral valve. What is away from the mitral valve is the right coronary cusp. So this is the right coronary cusp. What is on to the left side of the mitral valve is the left coronary cusp, and what is onto the right side is the right coronary cusp. Or in other words, mitral valve is behind the non-coronary left coronary commission. So this is one cusp, this is another cusp, and this is the right coronary cusp. So now let us go back to our VSD. So now we are exposing again the right ventricle. Our importance is on the perimembranous septum. So we are going to be putting in a perimembranous VSD. Sorry. So we are going to be putting in a perimembranous VSD. It is located in the region of anteroseptal tricuspid commissure, close to the conal muscle of Lancesi. This is the conal muscle of Lancesi, and this is the perimembranous defect. So now I am bringing out the left ventricular surface. Actually going obliquely. Okay, take the same blue pin. Once again, no. Can you expose this? Sorry, this one also. This. Slippery. I will now again go back to the right ventricular surface. So in the right ventricular surface, the VSD is located in the region of anteroseptal commissure, and on the left ventricular surface, it is located in the commissure between the It's located in the commissure below the right coronary, non-coronary cusps. So this is the non-coronary cusp. This is the right coronary cusp. You are able to see the right coronary artery here. That is the right coronary artery. And here is the left coronary cusp with the left coronary artery as a left coronary. So this is the perimembranous VSD. Now let us go on to get the subsequent VSDs. We are now going to have the intraconal VSD. So the intraconal VSD is located bang under the right coronary cusp, and you'll get it. Becomes so thick. Let's do one thing. We'll put in a longer needle so that it goes in, and then we will use. Just a second. No. Now we will use that. Take that out. Take it out. Located a little below the pulmonary valve, and it is related to the nadir of the right aortic sinus. Now we will put in the third VSD, which is subpulmonic VSD. The subpulmonic VSD will be on the first day we retained the heart in a softer way. And then what happened was the heart started to degenerate a lot. So we put it in formalin. Okay. Now you see that these are the three ventricular septal defects: a perimembranous VSD, an intraconal VSD, a subpulmonic VSD. These are basically like a necklace around the left ventricular outflow tract. A perimembranous VSD will be on a short axis view around 9 o'clock to 10 o'clock. An intraconal will be between 11 o'clock to 12 o'clock. And subpulmonic VSD will be between 1 o'clock to 2 o'clock. So these are the three VSDs. Now when you look at it from the left ventricular surface, when you look at it from the left ventricular surface, all are in relation to the right coronary cusp. So this is the right coronary cusp. The perimembranous VSD will be in the commissure between the non-coronary right coronary. The intraconal will be immediately below the belly of the right coronary, and the subpulmonic will be towards the left end of the right coronary, very close to the left coronary cusp, but on the left end of the right coronary cusp. So these are the three. All these three are basically subaortic. All these three are related to the aortic valve leaflets. In a perimembranous VSD, either the non-coronary cusp or the right coronary cusp can prolapse because of the venturi effect. In an intraconal VSD and subpulmonic VSD, the right coronary cusp can prolapse, not just due to venturi effect, due to intrinsic defect of the ventricular-aortic junction at that area. So this right coronary cusp prolapse in an intraconal VSD and subpulmonic VSD can start even in very early infancy, whereas the right coronary cusp and non-coronary cusp prolapse in a perimembranous VSD often starts later. It cannot start in neonatal period because there is no pressure gradient. It starts much later and it peaks at around 8 to 10 years. So the incidence of right coronary, non-coronary cusp prolapse with the perimembranous VSD due to venturi effect is peaking at 8 to 10 years. Now we will go back to put in the other types of VSDs. The next type of VSD is an inlet VSD. An inlet VSD is technically located below the tricuspid valve leaflet. So now taking the tricuspid valve leaflet. So this is the tricuspid valve leaflet and this is the inlet VSD. This inlet VSD will be located, again I will use the pin, longer needle. So if you look at the right ventricular surface, an inlet VSD is located behind the septal tricuspid leaflet. So this is the septal tricuspid leaflet and it is located behind it. On the same inlet VSD will be located beneath the mitral leaflet. This is the posterior part of the anterior mitral leaflet which you have cut off. So this is that inlet VSD. So we have seen now the perimembranous VSD, inlet VSD intraconal VSD and subpulmonary VSD, both these are outlet VSDs. We'll now go on to put in mid-muscular VSD. We'll try to put in apical muscular VSD. We'll try to put in anterior muscular, one long needle. Both are getting green color. Okay. Now here you give another color. Yellow. Okay. Little anterior. And one posterior muscular VSD. Now we'll see all the VSDs from the right side. Inlet white, perimembranous beneath the anteroseptal commissure near the conal muscle of Lancisi, intraconal yellow, subpulmonic red, anterior muscular VSD yellow, mid-muscular VSD green, posterior muscular VSD blue. Posterior muscular VSD was the yesterday's VSD. That boy who had a VSD which we closed was a posterior muscular. This is the apical muscular VSD. White is the apical muscular VSD. So correspondingly, the whole of the interventricular septum on this side. This is the anterolateral. This is the anterolateral papillary muscle and the posteromedial papillary muscle. The papillary muscles are not attached to the septum. They are away from the septum. So the place of the VSDs will not be in relation to the papillary muscles. It will be inside them. So this is the apical muscular VSD. This is a posterior muscular VSD, mid-muscular VSD, anterior muscular VSD. This is a subpulmonary VSD, intraconal VSD, perimembranous VSD, and inlet VSD. So these are the various locations of the ventricular septal defects. So we come to the conclusion of today's session. Needle on this side. This is at the apex of the right ventricular infundibulum. I'll show the right ventricle once again. So this is the triangular right ventricle, the inlet septum, the inlet septum, the perimembranous septum, intraconal, subpulmonic VSD, anterior muscular septum, mid-muscular, posterior muscular septum. This is the apex of the right ventricular infundibulum. So I have put in a needle here, and corresponding to that needle, it actually exits out here. So this is from the left ventricular apex towards the right ventricular infundibular apex. This is the left ventricular apex to the right ventricular body apex. So this is the apico-infundibular ventricular septal defect.